Hello, and welcome to the second webinar on benefit package design for universal health coverage. Today we will look at Indonesia as a country case and review the findings of a recently conducted assessment on financial sustainability and coverage effectiveness of the Indonesian Health Insurance System, with a specific focus on benefit package design and pharmaceutical policy. The webinar is organized by the German Development Corporation through the program Global Alliances for Social Protection and the sector initiative Social Protection, both implemented by GIZ. The assessment we will be looking at today is part of the German contribution to the EU Social Protection System initiative. More outcomes of this EU initiative will be presented here soon on socialprotection.org. So please stay tuned in the coming months. There will be more webinars to watch. Click, please. Next slide. So, dear audience, you can submit your questions to the panelists as we go, and we will address them during the discussion. Please note, as we have a global audience and we want to have an interactive session, we will have Q&A breaks. So please post your comments and questions right from the start so we can address them as we go. Thank you. Next slide. Our presenter today is Ioana Ursu, who conducted the system assessment in Indonesia. Hi, Ioana.
Hello, everyone. For those of you who are joining now for the first time, my experience is in the pharmaceutical assessment, so pharma background. I'm a pharmacist by background. I also have quite a bit of experience in decision making as Secretary of State of Romania quite recently, including the reform of the pricing methodology, so one of those topics that burns, and the HTA. Hopefully, my experience is going to help many of you today in assessing and looking at your own systems, and of course, open floor for questions.
Thanks a lot. And for those of you who joined us during the last webinar in October, you have already met. And yeah, we are happy to welcome you again. Thanks so much for taking your time and join us.
Thank you.
Click. I'm also particularly pleased to welcome our discussant today, who is one of the most experienced and senior health system expert in Indonesia, Professor Dr. Hasbullah Tabrani. Hello, Professor. Are you there with us? Yes, thank you. We cannot hear you.
Hello, everyone. My name is Hasbullah Tabrani. I'm currently Senior Health Managing Advisor at the National Social Security Council, the institution that oversights the management of national health insurance.
Perfect. Thank you so much, Professor, for joining. Next slide. That's a quick one. That's myself. I'm Victoria Rabowskaja. I'm the Regional Coordinator for Asia at the GIZ Global Alliances for Social Protection. And I was co-authoring the report on Indonesia and will be your guide through the session today. So welcome, everybody. And let's have a quick overview of the agenda in the next slide. Click, please. So Ioana will first take us through the methodology of the assessment, which is based on a systematic framework which she uses to map out health system functions. We will then dive into the findings from Indonesia. As the assessment was quite extensive, today we will focus on some examples and highlights only. For more details, please go and check out the full report, which is also linked in the invitation text which you received. Finally, we obviously will have a discussion with comments and insights from Professor Hasbullah, as well as a Q&A with you, the audience. So please feel free to comment and post questions. We are happy to engage. Okay, so far for the logistics. Now let's move to the Indonesian context. Click, next slide, please. So here are just some background key points to explain a bit the rationale for the assessment. As many of you know, the National Health Insurance in Indonesia, JKN, was introduced in 2014 and established a single payer system, which up to now covers already 170 million members. As you can imagine, such a reform does not go without challenges. So especially in the first years of implementation, two main aspects of concern appeared for policymakers in Indonesia. Firstly, that the fund, the health insurance fund, was running into a significant deficit, well over 10%. And secondly, at the same time, insured patients still had to pay out of pocket sometimes at facilities. So based on a request from the government of Indonesia, as a first step, we were looking at the root causes of out-of-pocket expenditure empirically. And it was not a big surprise when we found that the key drivers for out-of-pocket expenses were medicines, which patients had to pay for despite that they were insured. Also, the fund deficit was projected to remain for the coming years. So it was clear for us that better cost containment and expenditure management is needed for the fund to sustain. Consequently, after those diagnostics, the goal was to find practical policy options to better balance the available resources on the one hand and the benefits provided by the fund on the other hand. To do this, we decided to take a deeper look at the current benefit decision-making processes in Indonesia, as well as the pharmaceutical system as a whole. And for the overview of this exercise, I would like to give the floor to Joanna to guide us through the method as well as results of the assessment. The floor is yours.
Thank you, and click. So in order to identify what's triggering the high out-of-pocket expenditure, but also that issue of sustainability, or specifically the coverage for drugs, because by all means this is, it's not just the drugs within the insurance, but also the services. We decided to do an assessment, an in-depth assessment of the situation and of the stakeholders in Indonesia. So first thing, together with GIZ, we have identified all potential stakeholders that were involved in various moments in the decision regarding what gets reimbursed and why. But also then we had in-depth interviews with all the various stakeholders, and then a workshop in which we brought everyone at the table to show them what we had identified, what not, and also agree on what were the strengths, but also the potential weaknesses, to then make sure that we have covered all the bases and all the different aspects. So the system was evaluated across 3 dimensions. Click. The dimensions and this framework that we are presenting in the following next slides were already presented in the previous webinar in October. For those of you that have not had the chance to join us back then, the recordings are online. I will have a refresher right now, but we will not go in as much depth as last time, because of course this is about the actual implementation or the applicability of the framework rather than just the framework. So like I said, the first dimension of the pharmaceutical framework when we are assessing the system is to assess whether all mandatory functions of the system are present or not. And we're going to delve into what we understand by pharmaceutical functions in a second. Click. Once we have assessed the presence of the functions, then the question will be, what is the decision sequence between these functions? In which order do they function? Is there a continuous or coherent order, or does it jump around, or also it varies per drug, etc., etc.? 3, click. We then looked at the information flow. So how does the data from one stakeholder move to the next stakeholder, or from one function to the other? In an ideal situation, and we're going to discuss that, we have a clear flow of information between all the stakeholders and all the functions in the system. Click. Like I said, we're going to look now back, please. We are going to look now at the functions of the system. Again, for those of you who haven't been here in October, please just have a click through, make sure you understand, raise some questions, but we also have the webinar from October. So the first function of a system click is the regulatory, is what most of us understand when we say FDA. So the Food Drugs Administration in the US, European Medicine Agency in most of the European countries, any kind of regulatory agency that we have. So this is the function is fulfilled generally, like I said, by an agency. It's that unit that grants the market authorization. They establish that the product is safe and also that the standards of quality are there. Click, please. The next function of a system, of a pharmaceutical system, is actually the scientific or kind of the clinical review. We all have, in most of our countries, we all have a clinical group. We have a group of doctors that varies per disease, or it's the same group of doctors with maybe some pharmacists, some biotechnologists maybe, who will be looking at the clinical data, and they will decide whether the product from a clinical perspective should perform and will perform in our countries, and will also decide if this drug is better than what we're having or not. Click, please. The other function of a system is generally a unit or several is rather new. So this exists for the last 20 years in most of the Western countries, and it's almost kind of like the new go-to function that everyone wants to get when they're establishing their reimbursement systems, and that is the pharmacoeconomics or the health technology assessment unit. Countries like Philippines are now in the process of implementing it. Countries like Russia, they've implemented it in the past 3 years. This is that group of people that will try to relate the clinical performance to the actual value that is demanded. In other words, to price. This unit will look at things like affordability, will be looking at things like budget impact, they will be looking at cost effectiveness analysis. Click, please. The next function of a system that is very visible and exists in all of the systems around the world is actually the pricing and then reimbursement decision. But it's also the most visible unit, is the more of the pharmaceutical system. It tends to be that unit that goes directly to the Secretary of State. It's a decision on at what price a product will be covered, and also then if at that given price and for that given volume the product will make it into the reimbursement list or not. So as you can imagine, it tends to be the most contentious type of decision. The next click. The next function is more the administrative function. We call it in Europe, we also tend to call it the payer. In most of the other countries, it tends to be formed by initially the unit that looks at procurement, so public procurement agencies. It's more of an administrative function. It is also it will be the units that will be looking at relating the price, the volume, to the actual service. They will also issue rules about how a product should be used, but also how the physicians, which types of physicians are allowed to use and prescribe a certain product. Next, please. Last but not least, the monitoring function. This is the unit, again, or units, who will be looking at what are the volumes being used, what medicines are being used in reality or not, how many patients are we covering or not, how many services we are managing to cover or not, and also and overall puts all the data together and feeds back the data to all the previous functions by saying the reality is in our country that we use mainly that our diseases are mainly this, that our patients may tend to use this versus this. So this is the type of information that is being collected and then fed back into the system. Click, please. As you have seen already by putting and already saying this is the first function, the second function, in an ideal situation and in the systems that we have seen work, the functions come in a certain sequence. So there is a reason why the regulatory was the first one and then it was going to the clinical review. There is a reason why the system finishes with the monitoring, which then feeds back to the whole system. And that is, so genuinely the regulatory should be the first point of entry, and then the exit should be the monitoring. This is important to remember because we need a well-defined and coherent decision sequence, not only do we need the functions. Click, please. So, like I said, what's very important will be the flow of information. So each of these functions or units, if you want to call them like that, each of these units will work with certain types of data. What's very important is that each of these units works exactly with the right type of information and also gives to the next unit the right type of information. And to make it a bit easier to understand, click please. Let's just take the example of the regulatory function. So the regulatory agency. What type of data do they use as input? So what do they use to make a decision? They use things like epidemiology, clinical trials, and quality of production. What comes out of the regulatory agency in terms of output is the marketing authorization and the clinical data as they reviewed it. And they said, okay, based on the clinical trials, the efficacy, safety, etc. is this. Click, please. This clinical data, together with the local practice, which will be added, is actually the input for the scientific team, so for the clinical team. They will be looking at the clinical data within the local setting, within the local experience, and then they will make a judgment, and their judgment is the output. The output represents the clinical value of the new product, but also expected volume, so how many patients we're actually expecting to benefit from this new product, and also a decision on whether clinical guidelines, if there are any, in the country should be updated or not. Click, please. The clinical value that just came out now becomes input into the pharmacoeconomics team. They also add the costing, and they will do assessments like cost effectiveness, budget impact, package, benefit package, or case rate, or DRG impact. And that's the output. Click, please. So this clinical value with the potential, with the budget impact and the package impact will become now the input for the pricing function. What comes out of the pricing and reimbursement function is quite clear. One, a price on which we agreed on, something that works for the volume and the clinical value that was brought on board and that we can afford. But also then, if we have all of that, we say, yes, the product can be included in the reimbursement list. Click, please. That information, the price, the guidelines, how they should be updated, the volumes, the budget impact, become the tools used by the purchasing and provider reimbursement function. They will issue on top of that things like hospital usage, which prescribers, which volumes we can expect, tenders, etc. So this is what comes out of this function. And then click, please. This information, as you can imagine, then afterwards will also be the information that will be monitored by the 6 functions. So the one which will be looking at what the rules say and what's actually happening in reality. So we can then adjust our decision based on what's happening in reality rather than just what we assume it's happening in theory. Click, please. What's very important, and as you can already imagine, is that this process that we've just described, it's exactly that, it's a process. It's not a static thing. We do it once and that's it. What we're trying to create is a way, is a pathway in which the information is moving through the system constantly. What we want to make sure is that as we do this over and over and over again, we become better and we have a better idea of what's happening in our own systems. So real world data becomes imperative, and ideally we should be looking at volumes, we should be looking at spread of diseases, mortality, morbidity, but also annual costs for the insurance. Based on all of this data, then all the previous functions, when they make decisions, they'll be saying, okay, what is the reality in my country? Do I need an extra anti-diabetes product or not? Do I need another HIV product or not? Then is this adding something or not? So please see this as a continuous process, and also it highlights yet again the importance of the monitoring function. So this is a bit of framework which we have used also to evaluate Indonesia, but also you can use to evaluate your own systems.
Thank you, Anna. Just a short break before we continue. Thanks so much for the introduction to this elaborated framework with the distinct functions you just introduced. So let me just clarify, where is the framework actually coming from? And do you find this full set of functions in every country? What if you don't? And is the full set, let's say, present rather in sophisticated systems which are further developed? And how can other countries get there?
Yeah. Well, I think actually this is a bit of a debate at global level. Recently, I have read an article which was saying that there is no common way of assessing pharmaceutical systems, and I was a bit taken aback. The framework comes from our experience, and mine specifically, working over the past 10 years across 74 countries. So I had the chance of working both at decision level in more upcoming countries, if we want to call them like that, or even supporting the major payers and the major HTA agencies around the world. The framework is based on the patterns that we have seen across both developed but actually emerging, or even as just emerging economies. It's in any of the countries we have seen the same patterns. So we have seen this pattern from 1 to 6 around the world, whether it was kind of like a very narrow or a very small beginning of the microinsurance, let's say, all the way to actually fully covered systems where we have the universal healthcare coverage, like most of the Western countries and most of the Eastern Bloc. So the framework practically comes from what we have seen in the world. Then what we have seen, however, is that the functions, their relevance, or kind of like their finesse, their experience, the more they were, each of them were developed, the more each of them had a clear role and pathway, the better the reimbursement system works. So in countries like France and Italy or Germany, UK, you will easily be able to pinpoint all of the functions, where they sit, and even the flow of information between them. As you move more to the east, so as you move more to the Eastern Bloc, the former Eastern Bloc, or as you move more towards Russia, you're going to see that it becomes, some of the functions are more expressed and some of the functions are less expressed, which is starting to, create issues. And then the flow, even in between them, is not as clear, and it's not as, what does that mean? The reimbursement becomes patchy. While it is there, the actual out-of-pocket expenditure tends to be quite big. And then as we move even more towards kind of like the emerging economies, which are just setting up the process, the less a function is expressed, the higher the chances that the reimbursement or the universal healthcare coverage aims are not being reached. And I think this is where, this is where we need to work on. But that being said, all of the countries can benefit from this framework, and everyone has something, like all of us, we always have something that we can strengthen.
Okay, great, thank you. So we are excited to see how this framework with the functions now applies to the Indonesian situation. So let's dive into that.
So click. So like Victoria just mentioned, let's see how does this apply, because we have a framework or another framework, we have some way of doing things. How does this apply to identifying our strengths and our weaknesses if we want to move more closer to universal healthcare coverage, and specifically covering all the drugs if possible? So click, please. In the first part, we said, let's review and let's analyze whether all the functions of the healthcare system or the pharmaceutical system are present. So at the top hand, we have all the functions, and then underneath, we've put what we have identified as units or stakeholders that were fulfilling the specific function. In the case of the regulatory function, like we just said, there is actually an agency quite well developed in Indonesia, which is called BPOM. Don't bother with the acronyms, especially in Asia, it gets manic. So the first agency, so the first point of entry is quite clear. We have one regulatory agency. What do? They mainly grant, they will be looking at the production, the safety of the product, the quality of the production, then they will be looking at the safety of the products, and then they grant marketing authorizations. In terms of the scientific or the expert review function, there are actually several groups of clinicians. They form what is called FORNAS, FORNAS being the reimbursement list. They have special groups of physicians that will decide for each of the diseases whether a product is good enough and how does it fit into the clinical practice. And then they also decide whether the product should be reimbursed or not. So as you can see, there is a bit already of a mix of functions in there. The third function, the pharmacoeconomics function, we have found it in two potential new units. There is at the time of the evaluation, in the pharmacy department of the MOH, there was a new unit with economists being formed, looking at things like volume and budget impact, and that was the pharmacoeconomics committee. Then we also found in the financing department of the MOH, so a different department than the pharmacy one, we found an HTA group that was being formed. And they seemed to be looking mainly at the cost effectiveness analysis for the service or for the intervention rather than for the product. So all in all, we found some two elements in two departments of the MOH. Then in terms of the pricing and reimbursement function, we have identified two stakeholders. One of them is the pricing committee, again, in the pharmacy department of the MOH. But then we also found a separate committee for DRGs. DRGs, disease-related groups. For those of you who have using it already, you might be used to the term, but practically this is a group of clinicians, many of them, but also economists, and they were mainly looking at for each of the diseases how much the hospital should be paid for, and the DRG should cover both drugs and services. So they establish how much we are paying, let's say, for one episode of hepatitis or one episode of asthma, acute episode, or how. So this is what they do. They establish the costing for that. But like I said, that was within the financing department, and separately the pricing of the product of the drugs is done by the pricing committee within the pharmacy department of the MOH. We then looked at who would be doing the purchasing and procurement of both drugs and services. So for the drugs, there is a procurement that is done by the Public Procurement Agency, and they issue tenders. So they look specifically at drugs and they do the tendering part and establish the national needs. And then separately for the services and for the DRGs, and for the contracting of providers, as in hospitals, we have the National Health Insurer. So this is where the JKN that Victoria mentioned earlier, this is the main provider, and this is the main agency in charge of that. Then in terms of the monitoring and the feedback function, we found some elements of it being done by the hospitals, in the sense that the hospitals give some idea of needs of drugs to the Public Procurement Agency, and separately they claim the services from the National Health Insurance, so they claim the usage for reimbursement. So that's a bit, as you can already see, there were already some things that were hinting that potentially there are some parts that can be strengthened. Click. And when we looked at which parts can be strengthened specifically, so that have just mentioned, several things kind of striked as we were just looking at the functions. So first and foremost was the function number 3, which is the pharmacoeconomics. It was at the time only recently established. It was performed by the 2 units, and like I said, the 2 units were not very clear on how they interact in between them or with the rest. The other thing that we have noticed is this combination of the, or kind of rather than a combination, more of a split between pricing and reimbursement functions. So the reimbursement part is actually given to the scientific group, and then the pricing decision is given to the pricing committee in different part of the MOH. Then the other thing that we have noticed clearly was the issue of the monitoring. There is no active monitoring function, so there was no specific unit in charge of strictly monitoring the usage of both drugs and services. There is some feedback, like I said, on volumes and cases from hospital claims, but it's more on a case-by-case basis rather than an actual continuous role that someone took over. I think that's a bit, and that was the first assessment of the functions and stakeholders. Professor, would you say that things have changed in the past 2 years, or?
Yes, Joanna. I would like to add some maybe explanation to make clearer for the audience that the procurement of drugs in Indonesia have been changed from the previous system, which in the past, when we still using the social insurance for civil servant. Actually, we already started the social insurance scheme since 50 years ago. That limited to civil servant that until 2013 covered about 17 million people. In those areas, we have the procurement by procurement, quote unquote, because the real procurement, the real purchaser, not the national insurance, but the healthcare providers. That's the starting of using national formularium. In the previous system, they just developed pharmaceutical lists. They negotiated with the industry, and they put the 3 lowest bidder as the list of drugs that will be covered, reimbursed by the insurance at that time. When we moved to the National Health Insurance in 2014, we changed the payment system to hospital and clinics. To the clinics, we for outpatient primary care, we pay capitation, including medicine. And for the hospital, we pay what we call it CBG, which is the derivative of DRG. That's also covered or inclusive medicine for acute care. However, for long-term, for non-acute care, for example, for hypertension or diabetic, the drugs supply is covered separately. Then it has been divided into 2 different providers, because we do have public providers, public hospital and public health care center, which belong to the government. Sorry. And because of the government, other government regulation require tendering process. It's considered public money. You cannot, each hospital cannot just buy drugs. They have to go tender process. In this part, then the Ministry of Health with the agency in what you call it public sector procurement agency work together to tender what we call it pricing tender. They don't buy the drug by themselves. Rather, they invite pharma company to submit a price and volume they want to sell to the member of the JKN within public healthcare facilities. Then the winner will be listed as the names of drug and the price. But for the private hospital, private clinics, this requirement does not apply. So the private provider can buy by themselves. This still continue to do until now. The only change in the last 2 years is the establishment of the one that you already mentioned there, which is the health technology assessment. This different from the national pharmaceutical list or the FORNAS, because the STA basically is a pricing committee that will assess and appraise whether a new drug should be included or should be covered, or the existing that should be excluded based on the economic and clinical evaluation. So the HTA group just started last year and started with a few studies. For example, they just finished with the hemodialysis and peritoneal dialysis and come with the proposed project to PD first policy, for example, to switch a little bit from the hemodialysis to PD, which is more cost effective. They did also some studies with some cancer medicine, just finished, but the application is not done yet. So the STA is just the beginning, at the very beginning. We work together with HITEP in Thailand and NICE in the UK.
Yeah.
So that's kind of the update. Yeah.
That's great. I mean, I was aware, as you know, these days I'm working in the neighboring country in Philippines.
Yeah.
So actually we are setting up the HTA unit right there. So they were in a similar situation that you currently see in Indonesia. So we are now implemented. We've created the first HTA unit, gone through the first evaluations, and just finally got them now to connect them to the pricing part. So for all intents and purposes, it also shows you how countries evolve, but it also shows you potentially where are the potential weaknesses, or parts that can work or not. So click, please. Like I said, first we look at the functions. Do we have it? Do we not have it? Then we look at the decision sequence. So then we establish, if you remember, we were saying 1 should go to 2 and 2 should go to 3. Okay, so click, please. Let's see what is the situation with the decision sequence in Indonesia. The professor just hinted earlier that things are changing. Let's see how things were back in 2016, and we can discuss afterwards if and how they're changing. The professor just mentioned some. So the flow right now goes a bit 1 to 2 and 2 to 4, 4 to 5, and then to a 6. Let's walk through this. So Indonesia, the Indonesian regulatory agency is the first step in the decision. Great. Then the decision is moved to the scientific group, so the clinical group, or the clinical review group, who both look at the clinical value, but also decide on whether product should be reimbursed or not. So the decision of the reimbursement is done early on. If it's a product, if it's a drug, the decision is then moved to the pricing. Once the drug says, okay, should be reimbursed, this decision moves to the pricing committee within the MOH. We're going to discuss more about how this pricing is done, but practically it's more or less a mathematical formula that is being done, in which they establish a maximal price, which then becomes the maximal price for the procurement agency that the professor also discussed earlier. They issue a tender that is done on the pricing, and then the hospitals, like the professor just mentioned, then they can just say, okay, so for that particular product, the main provider should be this for the following year, and we're just going to say this is the volume that we require, and they should be getting their products from there and pay the maximal amount as it won the tenders. What happens if, however, it's more of a product that comes with a new service? The decision, the the decision of the clinical team actually also moves to the DRG team, the DRG committee, who then should establish a DRG level, so, or a fee level that for the providers. And like the professor just mentioned, that fee should cover both the services and the drugs. And that decision then is moved on to the national insurer, the national agency, who will then implement it and make sure that the hospitals, when they make their claims, are reimbursed the right level. Let's make it click, please. What strikes from the beginning when we look at this is exactly the issue of number 3. So we see 1, 2, 4, 5. So the pharmacoeconomics and the HTA units at the time of the evaluation were not in the decision sequence. So we were aware that HTA decisions are going to be made. Some pharmacoeconomics information will be provided. We were not clear in which order or if and when they were going to be included. So for all intents and purposes, the decision was that. So let's make it a bit more practical. Let's assume we are looking at an anticoagulant drug, which is something that is required in most of the hospitals in the world. So let's say the anticoagulant manufacturer looks at Indonesia, says, okay, I want to make it into this market because there are not enough competitors, or actually I bring something new to the table. Then they go to the number 1, to the regulatory agency, BPOM, who will be looking at clinical data. They will be looking at clinical trials. They will demand specific data for Indonesia. And then they will give, if everything goes to plan, about 1 year down the line, they're going to give a positive market authorization. Once that authorization is being given, the product could officially go in the private sector. But let's say that the manufacturer considers that, well, because this is a hospital drug, because this is mainly coming for infarct and stroke, I want to target the public sector because that's where the big volumes are. So in that case, they will make a request to the Ministry of Health to assess their drug. And the first group that will be looking at them will be the clinical group, the expert group, who will be looking at the clinical value of the product. And then let's assume they say, okay, this is clearly a need. We don't have anything in our reimbursement list that comes for this indication. So we're going to give, and there's a clinical benefit to this, so we're going to grant it reimbursement. So the reimbursement is being given. At this point, the manufacturer will go and discuss with the pricing committee. And by discuss, I mean they will be demanded to submit things like the cost of goods, the production cost, human resource cost, etc. And then they will agree on, there will be a price. Like I said, then that maximal price will go to the public procurement agency, who will make a bidding. If there are several competitors, assuming it's just one, just go to negotiation. They're going to say roughly, can you, it's not even a negotiation face to face, it's a bit of a discussion there. And then, and I'm saying that because they don't really have originals on patent products right now in the list. And then let's say all of that goes to the hospital level. You're going to ask me about what happens with the reimbursement in terms of the DRG. Well, it's the decision that new anticoagulant will also be transmitted to the DRG committee. And let's assume, for the sake of deciding, that the DRG is going to say, okay, we're going to create a new DRG for this, and we're going to allocate some money for it. The DRG will be set on international referencing, and they are going to say, okay, so this is the new DRG, and they're going to transmit the information to the national health insurer, who then will transmit the information to hospitals and say, well, for this new, if you have a stroke, and if you're applying this particular treatment with all the services included and with this drug, we're going to reimburse you this much. So that's a bit kind of like what's happening. You're going to say, well, it seems okay in theory. Well, let's just see exactly how does this translate in reality. Click, please. Click again. By merging the scientific and clinical review with the reimbursement decision, what happens is that the government has lost the capacity to negotiate. Practically, the manufacturer is interested to get reimbursement. That is their kind of goal. if we give them the goal up front without discussing volume, without discussing price, there is very little incentive for them to decrease the price afterwards. So first and foremost, by bringing up the decision to reimburse, we're actually cutting our capacity to negotiate further. Click, please. The other thing that happens is that by making the reimbursement decision prior to deciding on the price, but also prior on whether I can afford this or not, so whether I have the budget for this or not, what happens is that the current reimbursement list ends up being this kind of like fantastic wish list. So this is a situation that I have seen in many, many countries, whereby the clinical group was in a very, very awkward situation, in the sense that they were demanding for certain products to be included, and they were deciding that the products should be included because we need them, because as a country this is our need. But then the actual insurer is not capable of paying because the price or the kind of the list was never aligned to what we can afford. And then what ends up, the situation that ends up is this situation that the professor just mentioned, whereby we're going to start looking how do we delist products. And trust me, delisting products is considerably harder than putting them in, because you already have some patients on these drugs. You're going to create a lot of public pressure, and a lot of secretaries of state are not going to be willing to sacrifice votes for delisting. That is the reality. So that's a bit kind of like the issue. Then click, please. The other thing that we have noticed was exactly this issue that I was giving in the example, whereby the discussion on the price of the product is taken in the pricing committee without looking at DRG. In other words, what was happening, the DRG, or the cost that was reimbursed to the provider for both the service and the drug, we don't know if it actually covers the cost of the new drug or not. We have no idea. What happens in reality in most cases is that it's under or overpaid, so either or, you're looking at inefficiencies. The other thing is that what we're seeing actually in Indonesia, when we discussed with hospitals, was that there were many DRGs in which the cost that was being reimbursed was not covering everything, so actually not even all the services. So what the hospitals ended up doing were, they were using the DRG claims to mainly pay for their actual human resources and the actual running costs, and then they were asking the patients to go and procure the drugs outside the hospital, so pay for them out of pocket. In other words, we have found the main reason for which GIZ found out that there is a higher pocket rate. It had to do with the fact that DRGs were never really aligned to the prices of the drugs. So that was one big kind of like discussion and kind of gulping down, realizing what happened. It's, like I said, this situation is not uncommon. Again, I don't want to put it on Indonesia for doing the bad thing, because many of us do it. But this is why it's quite important to look at the framework and look who makes the decision on what grounds, to make sure that then we don't have these types of situations.
Thanks, Ilona. Again, to come in with a question on what you just said. So basically what we have seen that, yes, Indonesia has plenty of stakeholders who are involved into the benefit decision, whether directly or indirectly, they influence the benefit package, which is in the end the package which is supposed to be reimbursed by the National Insurance Fund. Whether it happens or not is again another question. So basically the goal of the assessment was to structure those institutions based on their functions and to bring out the sequence how they work together.
Yeah.
So we've seen this now, and we also, based on your presentation, we can see how the allocation of the functions one after the other can actually, so the presence is confirmed, but then the sequencing, how they work together, can actually also create some issues.
Yeah.
Right.
So not only, this is why I was saying earlier, it's quite important that when you're assessing your system to understand what's triggering the potential problems, don't just look if I have the function, look at how they interact and in which order, you know. So just take an example of any kind of product and speak with your own stakeholders in your own system and say, okay, how does this flow? How does this work through the system? And then if you follow, I call it follow the product, follow the drug. If you follow the drug and you follow the money, you also see how the decision is being made. So it's quite important that you look at the sequence.
Yeah, and now, so specifically in Indonesia, you highlighted two issues, so I would like to come back to them. So one is the establishment of the HTA, or pharmacoeconomic units, which in Indonesia goes to 2 separate units, actually. And as we know, because we have a global audience and many countries participating, I think this has been a global trend which countries are following currently. So to establish a HTA unit which would help to assess new products based on their cost effectiveness, for example, and then make decisions whether they fit into the benefit package or not. And this is supposed to help with the budget constraint which is present in any system, no matter how rich or poor. So this has been the approach quite in many countries, right? So, and as you also see it being established, I'd like to know that also based on the Indonesian experience which you presented, will it actually solve the issue? So in how far does it actually help us with this balance we are seeking for? So to balance the benefits and the ability to pay of the system. What is your experience on that?
Well, I have both very good experiences with it. I have very bad experiences with it, including my own country.
But maybe now also coming back to Indonesia, and then
exactly. Sorry, but you know, just kind of coming back to Indonesia. So if we were to consider in Indonesia right now that there is going to be, let's say, if we look even at this slide that we have right now in front of us, so let's just say that after this 2, you will then have this HTA committee, right? So after this clinical review, then you will have the HTA, which the three, right? The question still remains on how the information, or who will be using the information. Because right now, from my understanding, is that the information will go to the DRG committee. It will not go to the pricing committee. So the pricing committee still does their own thing. So we still haven't solved the issue whereby the price that they are setting will actually be reflected in the DRG. So I'm assuming that by bringing this unit in, we're actually going to kind of block and say, okay, so this unit now first makes a decision on whether this is cost effective or not. And then assuming it's cost effective, then, you know, we're going to look at price, the actual price. But then still the issue of budget impact remains, because don't forget that the cost effectiveness looks at one product at the time. So I'm looking at, we have to use the example of the anticoagulant. So it's the anticoagulant, the value of the cost effectiveness, so the additional benefit, clinical benefit of the new anticoagulant versus the old anticoagulant compared to the difference in price, right? So it's the additional clinical benefit for the additional price. That still doesn't solve my issue of budget impact, because how many patients am I going to give this to? That still doesn't answer my question. It also does not answer my question about the impact on the DRG. As in, you know, is this cost effective? When I establish the cost effectiveness, did I establish the cost effectiveness for the DRG, or did I establish it for the specific patient? So in other words, the HTA agency is going to help you only to the point where you let it help you. It depends on the information that you bring in, but it also depends on how you're going to put it into the system. Ideally, what needs to happen is that first this scientific review team does just the scientific part, just does the clinical part, right? Then it moves into the HTA, who will be looking at the additional clinical value versus the additional cost, who will also make recommendations on, hey, for our overall threshold, we need to have a decrease in price or recommended decrease in price of 70%. And we also, this team should also, on top of that, bring the pharmacoeconomics part of it. So do a basic, but at least, budget impact assessment and say, okay, we're assuming 70,000 patients in our country in the first year, who at the price that is being demanded will mean this much. Can we afford it? Can we not afford it?
Yeah.
And that conversation is where the BPGS the health insurer needs to come in and say, hello, I do not have extra money for this, so where do we cut from? So all of this discussion needs to be continuous, and this is where also at some point you bring the manufacturer in and say, okay, if we guarantee or if we are able to have 70,000 in 1 year, you don't even guarantee and say, realistically, we estimate this much. Can we agree on a price decrease of this percent? So in other words, the HTA will give you the value of one product at a time by cost effectiveness analysis. That's what I mean by HTA. You still need to bring the other elements in it. You still need to bring the budget impact in. You still need to bring the more general pharmacoeconomics of it.
And you still need the total volumes, right? Because you could actually have even a cheap generic, but then used in such high volumes that it will actually impact your budget a lot.
So this is a lesson that, for example, the UK only recently learned it. So as you know, the UK is, for example, we call it the motherland of cost effectiveness analysis. They were the first ones to come in. I was lucky enough to work in NICE in the first years. What happened is that while NICE was working and has been working very well as a kind of like a watchdog to make sure that everything that comes in is cost effective or not, we still have seen a huge increase in the budget used by drugs, or in the expenditure with drugs. And at this point, the Department of Health was said, okay, everything is cost effective, but I can't be paying for everything. So on top of it, as you may know, over the past 2 years, and actually this year 2017 became mandatory, it's not only just about being cost effective, but it's you have to be within a certain budget impact for you to make it into the reimbursement list. So they've also added back in the budget impact, because just being cost effective was not saving the budget, the fund.
Yeah, okay, thank you. So yeah, this is one HTA, if you have it, it should be placed at the right place within the flow, so it actually can influence your decision. And even if it influences your decision, you still also need the other functions to actually work to be able to create the final budget impact assessment and to be able to balance your budget and your package, correct?
Correct.
Okay, thank you. Looking at the time, I would suggest we continue with the next, and then I'm collecting the questions from the audience, which we will turn to after the last slides.
Okay, trying to rush through it, apologies.
Still have half an hour.
Okay, but still, click. So we have seen that the functions are pretty much there, but some of them could be strengthened. Then we have seen that the decision sequence is not really a sequence, and it's more of a jumping decision. As you can imagine, if the decision sequence is not there, what also happens is that mostly what we can expect by now, and you would expect so, is the information flow. So the data is also not necessarily there or jumping a bit around. Click, please. Where, by all means, this part in the report is a very big one. It's also quite specific for Indonesia, and I would like to focus on those elements which might be more common for everyone in the call today. So the takeaway message from this slide, if you look at this kind of like the left top hand side, you can see that where we have the green is where the information is there. Where we have the red, the information is not really there. What you can clearly see is that we have clinical information. what we don't really see when you're looking at the input, so the first part of the slide, the upper part, there's a lot of X's when it comes to anything related to real-world data. Anything from local clinical practices to local volumes to budget impact to hospital usage, all of those product usage, all of those are missing. As you can imagine, then also the output will be lacking or not as complete as possible. It also means that one function is not able to perform because they don't have the information from the other functions. So takeaway message is clinical data in Indonesia is most readily available. Like in many of the countries, we have doctors that are very good and trying to do their best. So at least the clinical data is there. But then the actual economic data, which comes more with monitoring, with setting up systems, tends to not be present. As the countries evolve, this data becomes available. Click, please. So even when data is available, however, there is scope for improving. So one of the basic examples, and I've seen this not just in Indonesia, in many countries, and this is why I've chose this as an example, is how you need to make sure that even if the data is there, it is transmitted forward. And the most basic example is actually the communication between the regulatory and the clinical teams within the MOH. So as you know, both regulatory agency and the clinical doctors within the MOH, that group of decision makers, review clinical trial data. They both look to, these are two parts of the system that will be looking at things like efficacy and comparator. How does it compare to what I'm actually doing? However, what I was seeing in Indonesia is that either they were using the same groups of physicians in two situations, so the same physicians using them twice, doubling their effort and their time, or the other thing that we have seen is that they were using other groups or other people, and then what was also happened, and sometimes it happened, is that they were reaching different conclusions. So while the regulatory agency was saying, yes, the data is good enough for you to have market authorization, the clinical group was saying, well, it's the right comparator. So what was happening was a duplication of effort, and also the potential demands for the manufacturer who didn't understand what they need to be doing. That was creating a lot of confusion. The solution is rather simple. Make sure that whichever way or whatever evaluation was being done internally in the regulatory agency is actually transmitted forward to the clinical team. Many times the regulatory agency, the only thing that they transmit or they give or they announce publicly is the market authorization. What is quite easily done is to demand them to also, that evaluation dossier, to also transmit it forward to the clinical team. It's a rather easy way of doing things. However, we do recognize that from a governance perspective, many times it tends to be a bit of a difficult one to implement, because many times the regulatory agency responds to a different decision maker, stakeholder, maybe the Secretary of State, but maybe the Prime Minister, as opposed to the other group who's more low-key, less seen within the Ministry of Health. But it is easy. It's just a question of creating a shared database, or just make sure there is transmission of documents across. Click, please. When we looked again at the flow of information, but also the information that is being used, I also wanted to highlight specifically the pricing methodology. Like I said, this is one of those key areas that remains a problem in many of the countries as they evolve or they set up the systems. In Indonesia, the pricing methodology is a mathematical formula. So it's a production cost multiplied by 4. And by production cost is mainly a question of cost of goods, cost of transport, cost of, because if they're not made in Indonesia, or cost of human resources if they're done locally, and then they multiply by 4. When I've tried to understand why by 4 and not by 7 or by 3 or by 2, it was more kind of, this is the way it was always done. The issue is that in this case, the price does not really reflect the volume. So if you might end up putting a very high price on a high volume product. So then for the system, it ends up being very expensive. Or the other issue is that you might end up putting a very low price for something that is a very low volume. And then the manufacturer has no incentive to bring the product to the market. So then you end up not having it. In parallel, what we have seen is that issue where the DRG costing was separate from the drug, and again, it disincentivizes the manufacturers from trying to have a price that fits the DRG or that fits the capacity of the system to pay. The technical solution is not an easy one. It's mainly revising the pricing methodology, making sure that you start considering things like volume of patients, burden of the disease, the budget impact, local therapy. However, if you have all the functions before, if everyone does their role, things can fit in together and things can and it can be done. The other thing that is quite important, as you can imagine, is that it's as much as possible start collecting your data. So monitor prescriptions where you are able, and don't just monitor how many cases of asthma did I have, but in those cases of asthma, which drugs were more prescribed, in order to establish the actual utilization and the actual need. Click, please. Just because I'm wary of the time. So, in other words, by using the framework, so the webinar today was how do you use the framework to identify your issues and what can you do about it. Of course, what can you do about it is that once you identify the problem, then you can come up with the technical solutions. Then on top of that, add the political solutions. But at least initially, you need to identify the issues and then come up with, then you can come up with solutions. So when we evaluated Indonesia, several conclusions came up with. Click, please. In terms of mandatory functions, all functions are present and the system therefore should be able to perform. The pharmacoeconomics and monitoring functions are not yet fully expressed and could be strengthened, and that is definitely going to add value and add information in the system. Click, please. The decision sequence, however, should be reconsidered, and we recommend in our report that the reimbursement decisions should be postponed until the volume is assessed and until pricing agreement is reached. As the pharmacoeconomics and the HTA come in, those elements should also be considered prior to making the reimbursement decision. Click, please. Then, of course, in terms of the information flow, and in terms of tools and in terms of methodologies being used by each of the functions, we recommend that at least there is a clear exchange between regulatory and clinical functions, so to speed up a bit the process, because from entering the system to actually being reimbursed, we are looking at anything from 6 months to 3 years. But then also, as much as possible, update the pricing methodology to reflect now the more sophisticated system, because the current methodology is quite old. Then also update the DRGs in line with the actual drug prices to lower that out-of-pocket expenditure. And of course, monitor medicine prescribing and expenditure to have an idea of what's actually happening. And when and as required, other cost containment tools can be brought in, like only certain specialists should be prescribing a certain drug, or only a drug should be used only after lines of therapy A, B, C. But you cannot make these types of decisions until you have an idea of what's being prescribed, when, and by who. That's about it.
Wow, thank you. So I think what we have seen, as you mentioned, are some of the identified issues which could be of relevance for other countries as well. So specifically the communication line between regulatory and the next function, which is a clinical assessment. From your experience, that's often a struggle or often a gap of information flow?
Including in most developed countries, yes. Exactly.
So this also has another aspect which you mentioned in terms of governance and actually, well, changing responsibilities. And did you have any experience in practically changing such communication lines?
Yes. So I don't know how many of you are aware of the European system. So we have a European Medicines Agency, which decides for 28 member states. It's a fantastic agency. It takes a lot of the workload from all of us in terms of country level decisions. And in the first few years, they were mainly given marketing authorization. Of course, they were publishing most of the data on which they were making the decision. But then most of us at country level were a bit left baffled on how should we use the information, or, you know, we still needed to start from scratch with the clinical trials. So then we would end up going back to them and asking them, can you give us more data? It didn't go very well in the first few years. And it has to do with the fact that we have things like the WHO PQ is the equivalent of EMA or FDA in the US, or, so, you know, the idea is that they work across the world with very, very important standards, international standards of quality. So adding this to them because they feel like it's something that it's added to them, rather than actually we're trying to, you know, streamline our own services. Let's just say that it can be a bit of a fuss. And they can also say, well, but you don't understand what we're doing. Well, actually we do. We just want you to be more open. However, once they understood what is it that we needed, and it would, you know, they also got their own kind of like paper with ticking boxes, what is it that they need to transmit, it became a lot easier. So they're like, oh, okay, this is what you want. And then they just shared it. So, like I said, it can be initially tricky, but as long as you speak the same language as them, and it might help getting the clinical committee to speak to them, because then they speak the same language. So they understand what information.
So there can be tools and methods to actually also move some pretty much processes which are pretty stable and seems very hard to move, but it can be done. Okay.
Correct.
Professor Hasbulla, are you still with us?
Yes, I'm with you.
To get you back and to get your view on maybe also a governance issue. So we have seen the establishment of the single payer in Indonesia. However, we also saw from the flow and the actual empirical evidence that we still had out-of-pocket spending as a challenge. And now we have seen all those different issues on different levels of different functions. From your perspective, would you say that BPJS, the Indonesian insurance, should it have more power or more influence in the flow of decision making? Do you think it's a governance issue which results in the deficit which BPJS is facing in the end, and out of pocket for patients on the other hand?
Yeah, I would like to explain a little bit previous issue that Joanna raised about the pricing as a production cost multiplied by 4. I was in the pricing committee before. That was coming from the historical and experience of the pharma industries, but it is not 4 times production cost. It is 4 times of raw material costs. So for the large volume, we assess in various generic drug, which is the Me Too including, that on average we can make it that to have the base estimate in order to put some price then by the Ministry of Health, that the pharma company then to bid within that. They can bid above or lower depending on the bidding, but for the estimate price, that's the one that used. Second explanation is the budget impact analysis. We do have the clinical committee that work since historically before the JKN, where they use mostly the economic evaluation, quote unquote, by benchmarking from other countries, basically from the literature only. when we starting with our GKN, we already started to establish HTA. However, it took 2 years to prepare the human resources and so on. It just started last year. So the HTA basically appraise whether a new product will be covered under the JKN or not covered. When the decision made, that's including the volume, the budget impact, then annually the pricing committee will negotiate for each year. So the budget impact, the HCA will make decision for much longer time, but annually, once it's decided to be covered, the pricing committee will negotiate if the drug is on patent. If the drug's not in patent, then they will go to the tendering process with the best price to be included. In the last 2 years, also we evaluate that in the past, when this study is conducted by GSN, there were many out-of-pocket payment for drugs. Then the new revision put the so-called top-up drugs, additional top-up drugs that's covered separately by the BPJS themselves. So the BPJS already had power to reimburse the drugs, special drug above the DRG payment level. So that's the new development. So we do apply your framework, but not in all drug with the same sequence. Some drug might be putting in the first number 1, number 3, and number 4, or the other one number 2 and 4, and then back number 3. So depending on the drug and so on. Regarding the deficit of the JKN, it was actually predicted, because since the beginning, the deficit coming from the political action that the government has been unwilling to create resistance or reaction from the public. So they start agreeing to set up the revenue below the one that we propose. That's the create deficit in the 4 years. But in the public insurance like this, like JKN, similar deficit for the first 4, even more than 10 years. I think in Turkey, in South Korea, it's same thing happening for political reason. We did last year with the National Social Security Council a project to start evaluating, assessing what we call strategic purchasing, to give the BPJS, the insurer, greater power to negotiate price and to assess. But building the capacity also a different issue, because not all the staff already familiar and competent to conduct such evaluation. So yes, there are problems, and they are increasing our national health account, showing that out-of-pocket payment increase. Why? Because a lot of people came to a hospital, and the hospital said because the DRG price not good enough, as you mentioned before, also happening. The hospital transformed the risk, the payment to the patient, and the patient certainly cannot reject that. They push to buy the drugs or pay additional price. In addition to that, some private hospital setting some quota. So when they put certain number of the JKN patient only to be accepted, to already the quota, certainly they cannot go to other hospital. They push to accept the condition that they will pay without using their insurance, and that's create additional out of pocket. So that's the the last update that I could give you on this one.
Yeah, thank you, Professor. So it's a good insight in basically showing that yes, Indonesia has made amazing progress in the last years, establishing all the new institutions and also establishing their working practices, but there's still quite some work load to do. Looking at the time, I would like to address the question from our audience. So I really like the first comment, how we should call the framework. I think that's a fair question.
It has already a name. The name is the Mapping Health Framework. So it will be published. I think GIZ already published it. And we are looking at also publishing it separately. Yes, and I'm flattered, but somehow I don't think my name necessarily is going to add a lot of value. So yes, it's more abstract than that, and there's a team effort behind it. So our framework is called the Mapping Health Framework. Thank you.
Good. So, and the next question is, it can be used to assess other countries.
Absolutely, that's the point of the webinar. Yeah.
To show the applicability, yes. So the next question would be, we know that out-of-pocket expenditure is a principal determinant of access to healthcare services. What are the measures put in place to reduce it, if not eliminate out-of-pocket
sorry,
expenditure?
Can you please say it a bit slower because I can't follow you and I don't see the questions.
Sorry, once again. We know that out-of-pocket expenditure is a principal determinant of access to healthcare services. So what are the measures put in place to reduce or even eliminate out-of-pocket expenditure? That's quite a broad question.
It is, and unfortunately there is no one single answer, but it's all the cost containment tools that everyone keeps talking about. So first, clearly it's the price. So when I'm talking about price, you have two ways of looking at it. Do you establish a price at the point of entry, as in the country, and therefore you regulate the price, or do you let it freely, which is the situation in the US? So that's the type of, the idea is that if you regulate it already at the point of entry and you manage to decrease the price, by definition, you can lower the out-of-pocket, right? Because the price is not that high. Then if you have a reimbursement system, like we said, it's all the discussion about volumes, etc., correlated, and then you decrease the price more. The other thing that you need to be doing, again, is to look at other tools like prescribers, controlling prescribers. And by controlling prescribers I'm not referring that we're going to go with a stick at them, but to make sure that as much as possible, you have clear pathways and recommendations on which types of drugs should be used in which line. In other words, the more expensive ones, if there is clinical argument for it, leave them for the last line rather than using them in a bigger volume. It's pure mathematics, simple things to do. For example, I remember in Germany how difficult this was to implement initially, when it was this demand of first you use the generic and then you use the brand. That being said, now it's a very common, very well accepted thing. So then the other thing that needs to happen is this information of the public on why the generics are as good as the brands, or on patent, off patent, etc. Then the other thing is, again, controlling prescribers limit the usage only to certain centers. So only certain prescribers have access or are allowed to prescribe certain drugs. Again, in order for that to happen, you need to have a good monitoring system and a good reimbursement system, right? A good way of making sure that the payer is able to see who prescribes it. And if the wrong type of physician prescribes it, they say, we're not going to cover it. So again, that type of power needs to be given to the payer for the out-of-pocket expenditure to go down. The other thing we've mentioned earlier is make sure that your DRG, so the level of reimbursement, is reflective of the reality. Also, don't necessarily put it up, but also put it down if the price goes down, to make sure that your budget is stabilized. So, like I said, there is no one fits all type of size, as type of answer. But I think it's a combination of tools.
Yes. So we are trying to find some
And
methods
yeah,
to work
and also
on it.
don't forget the importance of competition. So by competition, I mean not competition between providers, because actually I don't agree with it. I mean competition between manufacturers and distributors. So making sure that you have enough, or at least 3, wherever possible, suppliers, to make sure that there is competition and they will go lower with their price.
That leads us straight to the next question, perfectly, which is talking about the decision on suppliers. What is the criteria used to determine the best bidder? So I guess you're
in Indonesia. I don't know if the professor is still here to respond.
Yes, the question is how to determine the winner. Is that right?
Yeah. How is the?
Well, we do. It is for the non-patent drug. We just request normally in September and October, the Ministry of Health requests all pharma company to submit their drugs and price and related volume, and then it is electronically submission, and automatically just select the lowest volume for each province. So the winner will be listed on each province, not the nationwide, because the drug must be delivered to each province level. So the lowest price is win. We only select one winner. That's a simple model.
So it's not, Professor, correct me if I'm wrong, but
yeah.
It's not correlated to the volume that they are willing to supply.
Well, certainly volume is just the required for the industry to calculate how much they can sell because of the economy of scale. So they must submit what the volume they want to supply and the price. When they win the prize, they have to supply the whole volume in the province, because the volume already listed by the Ministry of Health, how much they needed volume for each province, for each drug. So when they submit, they should be able to supply the amount, that one.
And correct me if I'm wrong, but it's not exactly happening in reality, is it? As in many provinces don't have access to the lowest price.
Yeah, that's true, because until now there are problem in what we call it RKO, the estimate volume they submit because of the non-compliance of many actors, both hospital and the suppliers. Many hospitals, for example, say they say request they want to use 1 million couplet of ampicillin. In the end, they might buy only few, or they might buy over than that. So the industry estimate 1 million, but the utilization may be over or even below. That's create a problem in the area. Some industry then pull out because they, in the previous year, they produce 1 million couplet, but the absorption only 20%. So they said, why should I go there? So that's the problem at this time we are observing.
Okay.
Yeah. Looking at the time, I'm afraid we can take maybe one more question, and then refer to the online forum where we can post the replies to the others. So one quick question regarding, is it ethically acceptable to have the same people involved in 2 or more committees responsible for different functions? For example, a cardiologist is a member of scientific review group and DRG pricing committee.
That's less of a problem, to be honest. at least from my perspective, or at least in terms of how it works. My problem is when the cardiologist is also the leading scientist behind the main clinical trial done in the country. And that, again, is not uncommon. So the reality is that we don't have that many people. I mean, some countries like Indonesia are lucky enough that we are looking at 200 million people, and also we're looking at certain number of specialists in the country. Another country that I'm working currently in is Togo. They have 7 million people. As you can imagine, I actually met all the cardiologists, and they are under 30. Out of those under 30, the ones with high experience are 5. So of course you end up relating back to some of the same people. Ideally, of course, you would like to have a second opinion, right? You would like to have 2 in the regulatory, 2 in the clinical, and then 2 in the DRG committee. But then that being said, it can't always be the case.
Okay.
But yes, I as much as possible limit the accumulation of functions.
As far as possible. Okay, a very last and quite critical, or let's say a controversial question maybe. It's a great framework in sequencing. How this framework can be applied to the existing benefit package? It seems like the framework is more appropriate for making decisions over new interventions or new drugs coming into the benefit package.
Okay.
Very quick one.
Well,
we have 1 minute to wrap up.
It's easy. Take your benefit, look at the products that are in it, because at least that's the products, and say, okay, I've passed the first one. Do I have the clinical review on it? Yes, no. If I don't have it, what do I need to add? Then I go into the HTA. Do I have it? Do I not have it? Is it good enough? Can I improve it? And then it goes into the usual discussions about pricing, etc. So you can always revise how much you're paying for your benefit package by using the framework. Of course, you may not need the regulatory because the marketing authorization is there, but maybe you have now 3 competitors. So it's worth taking into consideration. So yes, the framework can be applied to your package. Just take your drug, look into it, see where you are, see what data you have on it, see what the flow is. And if you want to improve the benefit package, just pass it through the flow.
Great, thank you. So looking at the time, unfortunately, we do have to come to a closing for today. We still have some questions unanswered, unfortunately, but we do hope the presentation on the Indonesian situation was useful to you and you could take away some information which is transferable to your contacts in your countries. We would like to continue the exchange and conversation globally. So for the next steps, you will receive a follow-up email with the link to the recording of the session in case you want to go back or pass it on. You will also receive a link to the online forum for a community where we can engage. So as we did not manage to address all questions, we will post the replies to the existing questions there. If you have additional questions, please also feel free to post them there and we will come back to you. We posted actually the questions from the last sessions as well, so you can review them. Finally, you will also receive an evaluation questionnaire from us. We would really appreciate if you take 2 minutes to respond and give us your feedback, whether the topic is of interest to you and how you would like to continue to work on it. Please take the time to respond. We really appreciate that, to be able to engage and reply to your need as best as we can. Otherwise, I would really like to thank again our speakers, Joanna and Professor Hasbulla, and of course all the audience participating and actively engaging in the question bar with us. I wish you a good day or night.
Okay. Good night and good day, depending on where your location.
Depending on the continent.
Thank you. Yeah, depending on the continent. Yeah, it's going. Thank you. Great webinar. See you in next session. Thank you. Bye bye.
Thanks a lot, everybody. Goodbye. Goodbye.
Bye bye.
Bye.